Okay, I think we have now a question maybe from the audience.
Questions from the audience or questions here to the panel actually discussing the issues around this case. The first one would go to Peter, actually. What is your routine strategy with HBR patients undergoing PCI? So we've seen what's in the trial. What do you normally do? Where are the problems?
Well, first of all, identify your high bleeding risk patients. Radial approach, I think that's a no-brainer. Then I still would go for full revascularization, physiologically guided in many cases. I would select a stent which I feel comfortable for in the high bleeding risk patients, looking at evidence on trials and studies. I would then, irrespective of the complexity of the clinical presentation, I would give 1 month DAPT, irrespective of ACS or stable, and irrespective of complexity. But then I will drop aspirin, and after 1 month I will continue with a P2Y12 receptor blocker. But that specific choice of whether it should be clopidogrel or a more potent P2Y12 receptor blocker, that will be decided by the complexity of the procedure. So in this case, this complex case, I probably would go for a potent P2Y12 receptor blocker as monotherapy after 1 month.
Okay, so it all depends on the patient. Joanna, how does that influence, how does high bleeding risk influence choice of stent? Does it?
Yeah, I think it does. We have a lot of data now with 1 month anti-DAPT for a lot of the stents that are on the market. But I think, this stent with really good healing properties, which has almost no leaking Evans blue, I think that makes you feel very safe that you won't get any problems even within the first month from your procedure. So I think that this is particularly good technology to cut down on the DAPT use.
And you use that in clinical practice?
Yes, we are participating in the Pioneer 4 trial. So of course we are using the device in that trial, but also outside of it, yeah.
Okay, and then finally, Xavier, we're now switching tack. Was QFR useful in this scenario, and how?
I think it was very useful because remember that the first thing that Faisal and the team did was to assess what was the functional, the ischemic burden in the 3 coronary arteries, and actually they found that there was only 1 artery that had to be treated. As a matter of fact, Faisal might have recalculated the syntax score based on this to know what it was, and obviously now it will be much more in favor of PCI than it was before because it was only 1 vessel to be treated. The second thing is that they used the angiogram, which was already obtained, as a way of very information about ischemia generation by epicardial disease. So there was no need to do additional information. They knew already what they have to do. And finally, they had information in a way co-registered with the image because the functional information was obtained at the same time that you had a silhouette of the angiogram and a reconstruction of the lumen of the angiogram. They knew exactly which will be the target of the PCI. So I found it very useful.
Sjoerd Hofma from the Netherlands has a question. Sure.
Yes, very nice case showing all those aspects. If this patient now needs prostate surgery in 3 months, what would be your advice on, because they don't want to operate on ticagrelor?
Yeah, well, I mean, that's the interesting question. At the moment, for this particular case, the diagnosis was not made, patient was under investigation, but if that becomes the case, then we have to assess the risk versus benefit of the antiplatelets, and unfortunately, I think we may have to switch him back to aspirin for a short time, get his surgery done, and surgery needs to be as minimally possible because he's 86. So I think maybe switching back to aspirin for a short duration and then recommence the stronger antiplatelet post-surgery, that would be the normal clinical practice we do to taking the risk and benefit into account.
It depends also from when after the PCI, of course. I think that if you have to do by accident very quickly after, there are sophisticated way to do. I mean, I have seen people giving Cangrelor, yeah, because Cangrelor do the same as Ticagrelor, but in 5 minutes, and by the time you stop the infusion, the effect disappears. So I've seen people in that kind of situation going from Ticagrelor, Cangrelor, okay, then stopping the Cangrelor at the time of the operation, of course, and in the hours after, and eventually restarting the Cangrelor, because if you start to bleed, you can stop the Cangrelor immediately. So just testing the bleeding capacity of the patient, I would say. I've seen that also in bypass surgery. I mean, it has been practiced a few times to have the Cangrelor. You know, when the surgeon has finished, drain, nothing is coming from the drain, and so you say, okay, let's start the Cangrelor for 24 hours, and if nothing bleed in the Cangrelor, you go back to the Ticagrelor. So I've seen that. Okay.
Excellent point, actually.